so he's now our dean. But anyway, Richard and I go way back. We've done a lot of fun health reform projects together, and thank you so much for being here.
Your cousin says hello.
Good, I'm going to see you tonight.
Yes, you will. Named Figueroa, we call him Fig. I know a bunch of you from different walks of life and different things over the years. In my current position, I do work for the current governor, Gavin Newsom. He's off in El Salvador at the moment, which makes it actually a little more time than we have otherwise. In my deputy cabinet secretary capacity, I work on all the health and human services issues, and also work on veterans affairs. And the way this governor's office is organized is a little different from how governors have organized in the past. Typically, except for the most recent governor, the traditional way to do things was you have kind of a cabinet secretary and a bunch of deputy cabinet secretaries under them, and you have a legislative secretary and a bunch of deputy legislative secretaries under them. And what the legislative secretary does is obviously work on legislation, things that the legislature is considering for new statutes. And then once that gets turned over, once those bills are signed, it gets turned over to the cabinet side, who then works on implementing it. This current governor has kind of working in teams, and so the deputy legislative secretary works with the deputy cabinet secretary on things, both legislation, primarily the budget, and then implementation afterwards. So it's kind of a more team approach, and he also has a number of senior policy advisors that advise him on issues as well. So it's a fully operational battle star and fully staffed. And again, every governor kind of treats it a little bit differently. What's also different about this governor, I would say, and one of the reasons I came back, I had what I call an eight-year philanthropic vacation over at the California Endowment, where I was the director of prevention over there. And so the words what you were talking about resonated very strongly with me around the social determinants of health. Those are all the things you can't account for that end up in those changing those mortality statistics the way that they do. The reason I came back after my hiatus is because for the first time in at least my memory, we have a governor who actually ran on healthcare and ran on healthcare issues, which is kind of actually unusual for governors. They typically run on maybe education reform or public safety or climate change or the environment, but it's not very common that they, in fact, it goes back to Earl Warren or some time way in the past where they actually ran on healthcare. And not only did he run on healthcare, he ran on single-payer healthcare, which of course is even more controversial than just covering people. It's a broader concept about kind of reorganizing the way that healthcare is financed and potentially delivered. So again, that was kind of intriguing to me. I had worked on obviously previous proposals under different governors, including Schwarzenegger's plan, which was ended up kind of looking like Obamacare or Obamacare looked like it or whatever it was. But it really never went that full range, looking at the whole delivery system or looking at how to change the way that things are financed. So again, I came back to do this, and I want to just kind of talk to you a little bit about, kind of what the governor's vision. He's only been in office less than 100 days, and so I don't completely know his vision. I'm not sure he knows completely knows his entire vision either. But as represented in the statements in the past, as well as if the budget is at all a representation of your vision, I want to talk a little bit about the elements of the budget that kind of touch on some of the work that you do. The very first thing is, I joke about this quite a bit. If any of you are familiar with the California Endowment, it's this and that for all. It might be health for all, water for all, justice for all, this and that. And Daniel Zingali, who's the communications director for the California Endowment, is now the communications director for the governor. So shockingly, you have California for all. So there's lots of for alls within the horseshoe, as the governor's office is specifically called. It's in the configuration of a horseshoe. So you'll be seeing lots of for alls because that's kind of the language that has been brought in from TCE and foundation land. So just a little insight on that. That's it. I'm not sure how to advance slides here. Should I just do this?
Yeah.
It's a little quicker.
So Richard only sent me the slides last night at 9, so we didn't have time to iterate on these at all. So I'm learning along with everybody else.
Yes, I just haven't. I haven't. I'm so new. I haven't even done slides in my current position, and we don't have any either, even in the governor's office, which is just kind of all too new, so I'm kind of making things like go along. So just to kind of touch on some of the major healthcare themes, and I kind of talked to them, I spoke to people earlier. The governor ran on single payer. I don't, none of us know exactly, what that, well, it means many things to many different people. I'll put it that way. Is it like Medicare for all, or the current system, but it's reorganized differently in terms of its financing? Is it some combination of Medicaid and Medicare and block grants and Champus and this and that? That's kind of another kind of version. But within that, what the governor very recently put out as some language, he said a couple of days ago, that he wishes to see the legislature adopt this budget cycle, so basically within the next 2 months, that sets up a Healthy California for All, gee, what a shock, Healthy California for All, commission, that does 2 reports. So last year, when single payer was being debated, there was a Senate bill that was hotly contested. And the state assembly decided that wasn't the approach they wanted to take. And they, in lieu of passing the single payer bill last year, they set what's called the Council on Healthcare Delivery Systems, which had 5 people and was going to produce a report by the year 2021. The governor took a look at that structure, and there was no appointments made to it or anything. The previous governor said, I'll let the new governor figure it out. And the state assembly and the state senate also will just wait for the new governor to figure out what he wants to do. So what the governor decided to do is, in lieu of the council, which just had 5 members, he wanted to have a broader discussion with more members. So he released some language a couple of days ago that would establish this particular commission, but it would have 13 members. And it would have reports in kind of 2 distinct frames. One is, the first report would take a look at the current healthcare delivery system in California, and all of its prettiness and ugliness and warts and butterflies, etc. And give one report on that, which would be due in about a year. And about, number of months, 6 to 8 months after that, a report on what a future system could look like, a la single payer, and what those different structures might be. So broader composition in terms of the commission, and a much quicker timeline than the earlier council structure. I think, again, it's an indication his view was trying, in terms of the time frame, trying to get these reports kind of teed up, if in fact there is a more hospitable federal administration to kind of work with. I think, clearly, I keep my head down over the tweet wars between the governor and the president. They're all told to do, just stay out of it. And I think the governor doesn't necessarily want to pick a lot of fights with things. It seems like it ends up being kind of that way, but also would like us to cooperate with the federal government wherever possible. So it's just not a completely contentious relationship, one where we try to find some commonality and work together. I don't think we believe healthcare is one of them. I think the governor has been very, very clear about his support for many of the provisions of the Affordable Care Act, or Obamacare, whatever you want to call it. And so is an active litigation with our Attorney General and many other states against a Texas lawsuit that would seek to completely wipe it off the face of the earth. So, again, that's just an area where we're just not going to agree. And he's trying to tee up these reports, in case there's a more compatible administration, to have kind of a general conversation about how you might do some kind of innovation waiver, something where you have access to the federal dollars that come into the state, to match it with our state dollars and the funding streams, to see what we can do in kind of a different system than we have right now. He's also in favor of universal coverage. Again, not something that governors have run on before. I'm not sure he thinks he can get there overnight. I think you've seen in the budget this year, maybe that you don't know yet, but we already are covering the biggest chunk of remaining uninsured are really undocumented adults. The legislature and prior Governor Brown took a good chunk out of that by covering for the first time undocumented children, 0 to 19, and the governor has proposed in the budget to take the next chunk of low-income uninsured adults, which is the 19 to 26-year-olds, and add them to that account. Now, above that, there's still 1.5 million, 26 and above, undocumented primarily. There's also 800,000 legal residents in California who aren't holding that account, even though it's free. So there's, part of the group that doesn't really have any much in terms of affordability for them. There's also just a lot of other people that just haven't opted for Medi-Cal, even when it's available to them. He's also taken a stab at looking at slightly higher income individuals and seeing what he can do on the affordability side. I need to tell you that California is a pretty high cost state. Many people that are eligible for covered California can't afford it. So he's looking at providing additional resources for those persons in the covered California range, primarily between 250% and 400% of the poverty level, as well as for the first time, people in the 400 to 600% of the federal poverty level category. And again, in any other state, if you're talking about subsidies for people that are making $80,000, $100,000 a year, they might look at you kind of like you're crazy, but it's expensive to live here in California, particularly if you have a reasonable sized family. So he's looking to try to not just do something for the lowest income individuals, but also that working class, middle class group. And he's tying that to an individual mandate, which is, at the federal level, the penalty for the individual mandate has now been 0, so it's basically ineffective. So he's trying to set one up for California, tied to those additional subsidies. So if we do require individuals to maintain coverage, they'll have a greater chance of affordability to meet that challenge. He's also looking at this in the context of cost containment. And the governor's view is that, yes, I could have put $3 or $4 billion into the state budget and covered all the undocumented adults that are left. And the group, that's 27 to 50, 55 isn't that expensive. And it's just a real small amount that are older undocumented, but they're really, really expensive. The big chunk of those dollars goes to older, and particularly the above 65 population. But what he didn't want to do, he was very worried about the sustainability of putting in that much money right now into covering those that are left. He's worried about, kind of what the economy might do. He's worried about, this is the first year when I've gone through the implications on the state government for federal tax reform, and none of us know what receipts are going to look like over the next 3 weeks. Nobody knows. We've seen some very, very difficult numbers back east in New York and New Jersey, even heavily impacted so far. We have a little bit different tax structure out here, so we're hoping we're not as heavily impacted as those that have, had high deductibility for state and local taxes, the SALT, so to speak, is what it's called. But again, we don't know. So he wanted to go slow. He also wanted to see, is there a way we could get our own house in order a little bit better? And the way that he have started to look at it is the prescription drugs. The state buys lots of prescription drugs, and we buy it a lot of different ways. So we have our prison system, for example. We have our veterans hospitals. We have hospitals for persons that are mentally ill. We have hospitals that are pretty much closed down, but are still available somewhat for persons with developmental disabilities. CHP buys drugs. And obviously you have the behemoth known as Medi-Cal, and also public health, which buys drugs for persons with HIV and CB. It's on and on and on. So he's also thinking, gee, what can we do as a marker for the grand and beautiful tomorrow, where the state can better aggregate its purchasing power in a number of different ways? Can we at least start with drugs, where we know we have lots of different ways that we purchase right now? And can't we do a better job at consolidating and trying to get a better deal than we are right now? So I'm in the process of working with our different departments on what that looks like. And again, it's just kind of a marker for what the state can do more broadly. And we might be able to do kind of, I don't think we're under any false impression that we can just drive costs down. I think even trying to lower the curve, the cost curve, is pretty significant. So we're kind of taking a look at that. The other thing I think the governor's going to be interested is looking at is, market concentrations. It costs a lot more for health coverage in Northern California than Southern California. And that's because there's so much, we have much greater provider concentrations in the north than we do in the south. And let's take a look at that too. It's a little bit of a third rail for the provider community in some ways. The governors really haven't gone there. He wants to go there and take a look and take a strong look at that. Some of it's on the hospital side in particular. There's just a vastly different structure in the north than there is in the south, in terms of hospital chains and consolidation. But it's also provider groups. again, very different levels of concentration in the north and concentration in the south. So it's not just pharmaceuticals, but he does want to look at the broader context in which our current healthcare delivery system is structured. He also has a very, very strong focus on early childhood. If you don't know that already, then you haven't been paying attention, because we have a Surgeon General that's a pediatrician, our first ever Surgeon General, who's a pediatrician and whose main focus was on trauma-informed care and ACEs work, looking at the effect of cortisol, for example, in young children. And that very much ties to some of the data that you were showing, that if you don't do the right thing early, and because of social determinants, we already know kind of what the outcome's going to be, unfortunately, for a lot of these children in these high stress environments. So go ahead, Ted.
ACEs, just...
That's right, adverse childhood experiences is what ACEs stands for. And there's actually like different, people have developed kind of different scoring methods for trying to figure out what an ACEs score is. And obviously the higher ACEs score you have, the more trauma has affected you, both you and your family. And the more, it likes to be greater likelihood you're going to need some kind of behavioral health or other kind of intervention in your life as a result. And again, the higher the ACEs score, we also kind of know, unfortunately, the trajectory, statistically, where these children are going to be, and it tends to be, a lot less educational achievement, income achievement, and a variety of a lot lower life expectancy. It's like that whole thing. It's really about your zip code, not your genetic code. A lot of it is kind of comes out of the ACEs work and looking at early stressors. So the governor's very interested in a focus on early childhood. He's the first ever Surgeon General. Today he just swore in. He didn't do it, but we had a judge come and swore in our agency secretary at about 11 o'clock today. So we now have a new Health and Human Services agency secretary. That's about 11 o'clock. And Dr. Mark Alley comes out of LA County, and he's also a pediatrician. So we have two pediatricians as kind of the health leadership team in positions in the state. And I don't know if that's, the governor has 4 kids under 10, maybe that drives some of this, I don't know. but again, he's very, very strong interest in early childhood. He's put a bunch of dollars in to require for the first time health plan, there are a number of you in the room, to do ACEs screening for the first time, because health plans may have done it on their own, but now they'll be required to do it, and we'll also obviously pay them for it, as well as a much stronger emphasis on early developmental screenings. And this is kind of a part of a larger conversation he's having around early childhood ed that spans just healthcare. It also includes child care, a number of other programs where government may interact with a child's life. And so he's looking kind of across systems and trying to break down the silos that have existed between our health services side and our social services side and our behavioral health side. So he's trying to look across systems and ways we can braid dollars or braid the work that we do. Along the same thing, there's additional health plan metrics. We had a recent survey done by the Auditor General, or maybe the state didn't come out so rosy in terms of some of the health plan metrics associated with pediatric measures. And so the governor is going to be paying a lot more attention to those metrics and paying a lot more attention to how the health plans are, we're in mostly a managed care environment in Medi-Cal, for example, and paying much stronger attention at health plan metrics for kids, and going to a much more stringent approach where we're going to look at all the measures, and if the measures aren't met, not only would plans be subject to corrective action plan, but financial penalties as well. So much stronger focus on that particular thing. The other thing I would say is as part of this, we're using a lot of Prop 56 money, which is the tobacco tax, to work with plans on special projects related to both early developmental screenings, but also related to behavioral health integration comes across the ages, and chronic disease integration as well across the ages. So we're not leaving out, I think it's something like 5% of the Medi-Cal recipients constitute 51% of Medi-Cal expenditures, and that top 1% is over 25%. So we also need to obviously, the same thing, work on children, kind of at a very young age. We can't lift our eyes from the chronically ill, lots of people have obviously comorbidities, the homeless. So we're trying to work on that strand as well. And I'll get to it in a second. The other area is older Californians. So we haven't really had a real strong focus on older Californians since maybe 2001, maybe 2000. Governor Davis had a plan at that time called Aging with Dignity, and we haven't really had a very strong focus on older Californians since then specifically. So the governor has, in his State of the State, announced 2 task forces. One is an Alzheimer's task force that's headed by former First Lady Maria Shriver, who was Governor Schwarzenegger's former spouse, although married when I was there. And then also a master plan for aging. There'll be like a task force or a working group around that as well. I think it's no secret to the folks here where we are facing a silver tsunami. And so, again, there's a little bit of silver here, and I have some more coming in my sites, my temples too. And the governor has had lots of recent experience with aging parents and past and things like that, so has been interested in working to see what we might be able to do to look across the spectrum around older Californians. I mentioned the defense of the ACA a little bit earlier. Obviously, that's an area where the Trump administration and California are not going to see eye to eye at all. We have done what we can in California to enshrine most of the provisions of Obamacare into California law, such that if a court were to invalidate it, most of the things like, these are things like, they're really not, again, California's a different place. The Republicans, independents, and Democrats are pretty much in sync about the importance of allowing people to continue to cover their kids to the 26. There's, 80-90% agreement that we're looking at. It's not a partisan or an ideological thing. Most people don't want to go back to the bad old days where insurers can say yes or no to whoever they want. They want to maintain, the guarantee of purchasing coverage even if you're ill. People don't want to go back to the days where you have annual or lifetime limits, for example. These are things that are now kind of enshrined. People kind of have gotten used to them. They like them. They don't want to go back to those days. And if even if the federal courts make a different decision, those things will be enshrined in California law. What is harder to do for California is to continue things like the Medicaid expansion. Or Medi-Cal as we know it here. So before Obamacare got implemented, before Obamacare got implemented, our Medi-Cal program was about $52, $53 billion. It's almost $100 billion now. And most of that big growth has come from the Medicaid expansion, which is 90% federally funded. If a court invalidated that, that'd be $20 or $30 billion overnight that California, or during some period of time, would have to come up with. We don't have those resources, unless we were to do some other, cut a lot of everything else, or find new revenues through some kind of general tax or something. So there's a lot at stake for California on the coverage side. Again, the market rules, the insurance rules, we could kind of do that. We could regulate insurance under California law and under the federal constitution. That's the purview of the states. But where we can't do as well is when there's massive federal dollars involved, like there is in Medicaid. We can't make that up very easily on our own because the dollar amount is just so much. It's just too big. So we have a lot at stake in this kind of general conversation in the defense of the ACA. Very last thing I'll say is we are expanding whole person care to include the social determinants of health. When you drove here today, you saw the encampment probably on the left side of the road. That's because the water, maybe are not from this area, that's because the water is high right now, and there's a lower area kind of on the other side of the bridge over here where usually people, there's large homeless encampments there. But right now those areas are flooded because of high water. So they're all kind of along here. So a lot of our whole person care pilots were fine in Medi-Cal as far as they went. Even our homeless projects generally were fine, but we were having a lot of problems with paying for housing vouchers and things like that. So we're expanding our whole person care pilots to include the larger social determinants, which include housing, actually, purchasing through vouchers or otherwise, trying to actually get people into a different environment than living on the streets or living in a tent by the side of the road. We're going to go through Medicaid. The feds won't match the housing voucher. They won't. It's not 50-50, but it's something we haven't tried before through Medicaid. And so we'll be engaging counties, local government, and health plans around that, because whether we like it or not, one of the reasons why plans have such difficult times of keeping people in treatment is because of all these other issues that impact their life. And so we're going to have to get to some of those things through the health system or related to the health system, whether we like it or not, to help stabilize individuals and get their get the diseases under control, and hopefully help them to get to a better place. The other thing is we're seeing more and more homeless that are older, and the governor's aware of that too. And so that's a particular focus on the older Californian side. More and more of them are seniors. As we age, so is the population of the homeless. So unfortunately, we're seeing lots and lots of seniors in that area too. So again, these are some of the major healthcare themes. It's kind of a lot to kind of chew on at the same time. It's a lot for me, that's for sure. We haven't had a secretary until today, so I might get hippies. I'm going to help someone help. Get a bunch of this work done. But it is a pretty aggressive agenda in a relatively short period of time. If I would have been here, representing Governor Schwarzenegger or Governor Wilson or Majan, probably would have been, I know, go back a ways. It would have been kind of a different thing because nothing was to the scale, and of course nothing on the scale of talking about single payer. This hasn't. The other thing is we haven't made lots of changes in government yet. I think even though people think we are a very blue state, we haven't had a governor or Democratic governor to Democratic governor transition since 1886. And so it's been 130 years since we've had a Democrat succeed as a Democrat. How many of you knew that? Right, and people just figure we're a blue state and this happens. There's no one living today that has seen a Democrat to Democrat transition in California. So we haven't made any changes in departments or anything. There's not a huge ideological gulf between the current governor and the previous governor. So it's not like other kinds of transitions where Democrat takes over Republican or vice versa, and they fire everybody and have a bunch of interims. Haven't had to do that because most people wanted to stay. And again, it wasn't some this governor didn't come from like a different branch of the Democratic Party. We've had situations where even the Republican Party, where someone came from a different branch of the same party and fired everybody, even the same party. So we're just now gearing up to do to take a look at positions. Again, we haven't had a secretary, so now we have a secretary. We can engage around that as well. So again, we've been busy on the budget side. We've been a lot less busy on the personnel side because we haven't had a secretary. There just hasn't been any real need yet to get to that level. So anyway, I just want to give you kind of a snapshot of what's kind of happening up here. The legislature's obviously very busy, and there's a lot of pent-up demand for more resources in health and human services, either because the previous governor vetoed a lot of stuff and they want to try the new governor out and see what sticks, or people they perceive that the governor is not maybe as thrifty, right word, I don't know what the right word is, as the previous governor. I do think this governor does want to really focus on what he can do with one-time money versus ongoing. He's not sure where the economy is going to go, so I do think he's going to continue to be careful. But again, it'll be his first go around at the budget stuff as well. And so when you talk about getting to zero, to me, I think about getting to zero in terms of HIV, HCV, and STD/STIs.
Heart attacks.
Well, only because getting to zero is the actual name of a national campaign around HIV and HCV. And so when I was around the corner, I said, I better see what he's talking about. Which getting to zero is this? Or another group is Stop the Epidemics. That's another group. And so we'll be looking very strongly at what's happening in the public health sphere as well, because we have so many big issue with STIs and STDs. I always want to call them, I was taught STDs and I was taught STIs, and now I start seeing these STDs again. What's the right term now? I'm looking over here at my public health folks. STIs, STDs. STIs is still, I can't keep whatever the norm is, I don't know, it's hard to keep track. Anyway, that's what's happening from the governor's office. We look forward to engaging I'm with you. We know very well